Stay tuned. Coming up is our interview with Dr. Deborah Korn and Dr. Richard Kamin discussing eye movement desensitization and reprocessing, or EMDR, a proven effective treatment to help first responders suffering from post-traumatic event brain injuries. Hello and welcome to the Situational Awareness Matters Show, episode 393. I'm your host, Rich Gassaway. The purpose of this show is to improve situational awareness and decision-making for individuals and teams who work in high-risk, high-consequence, time-compressed environments with changing conditions. The SA Matters mission is simple. We want to help you see the bad things coming in time to prevent bad outcomes. Today's feature segment is sponsored by Gassaway Virtual Training. There are 33 online training programs there for you to choose from. Some of the programs are live events presented virtually, and some of them are pre-recorded programs. To learn more, visit samatters.com website and click on the Virtual Training tab. Okay, let's jump into our feature segment, our interview with Dr. Deborah Korn and Dr. Richard Kamin discussing eye movement desensitization and reprocessing, or EMDR, a proven effective treatment to help first responders suffering from post-traumatic event brain injury. Dr. Deborah Korn is an internationally renowned pioneer and expert in EMDR therapy. She is on the faculties of the EMDR Institute in California and the Trauma Research Foundation in Boston. As an active and respected member of the EMDR International Association, Dr. Korn represents and consults internationally on complex PTSD recovery with a specialization in the treatment of adult survivors of childhood abuse and neglect. In addition to teaching, consulting, and maintaining a private practice in Cambridge, Massachusetts, she is involved in mental health advocacy, criminal justice reform, and combating systemic racism. She is the co-author of Every Memory Deserves Respect, EMDR, the proven trauma therapy with the power to heal. And she co-wrote that with Michael Baldwin. For more information about Dr. Korn's book, you can visit the EMDR clinicians, or to find an EMDR clinician in your area, you can visit www.everymemorydeservesrespect.com. Our co-guest with Dr. Korn is Dr. Richard Kamin. He is a practicing emergency physician and associate professor of emergency medicine at the University of Connecticut Health Center, where he is the EMS program director. Dr. Kamin serves as the medical director for the Connecticut Department of Public Health Office of EMS. He is the co-chair of the Committee for Tactical Emergency Casualty Care, an active member of the National Association of State EMS Officials, Medical Directors Council, a co-principal investigator on the National Model EMS Clinical Guidelines Project, and a member of the ACEP High Threat Task Force. Dr. Kamin was involved in a response to the Sandy Hook school shooting and sought EMDR therapy to help him deal with the after effects of that particular traumatic experience. He found EMDR to be extremely useful and effective personally and promotes it as an excellent option to help first responders and trauma victims recover from their acute and/or recent traumatic events. Welcome to a very special episode of the Situational Awareness Matters Show. I'm your host, Rich Gassaway, and today I have two amazing guests. I have Dr. Deborah Korn, who is a specialist, expert in EMDR. And if you're not sure what EMDR is, all the better. Stick around. You're going to learn about it. And Dr. Richard Kamin, who is a physician who was a recipient of EMDR therapy following an incident that I'll let him share his experience about as well. And this episode is so critical for first responders because, as you know, firefighter suicide is becoming nearly epidemic level. And we really, really need to address this problem head on. And that's the focus of today's show. So to both doctors, welcome to the show. I'm glad to have you.
Thank you. It's great to be here.
Thanks very much.
Let's start with Dr. Korn. If you could, and you said call you Debbie, but I'm probably going to just default to Dr. Korn.
So. I'll answer to anything.
Let's start with maybe putting a frame around trauma and how do we define that in the context of what first responders do and what they're exposed to, and maybe even trauma as it relates to things that might have happened to them outside of work or in other aspects of their life, even maybe early life.
Yeah. Well, trauma is a part of life, right? 70% of adults have experienced at least one significant trauma in their lives. That's what the statistics tell us. But we know trauma is a part of life. And in our book, we define trauma as any experience that feels overwhelming, that triggers strong negative emotions like shame or terror, and involves a sense of powerlessness or intense vulnerability. And I always like to say that trauma is both objective and subjective. So it's both the event, what you're facing right in front of you, and it's also your experience of the event. So what might be traumatic for one person is not necessarily traumatic for the next person. It depends where you've been in your life, what resources you're bringing to the moment, what your expectations are, how prepared you are, what the messages you get about that experience are, how you're treated after the event. There's so many factors that are going to determine whether an event is experienced as a trauma. So it's not just what happens to you or what happened to you, but also, and maybe more importantly, what happens inside of you, right? We also know the greater the number of traumas that someone's exposed to, the greater the psychological toll, the greater the physical toll. So when we're talking about first responders who, are facing trauma day in and day out, traumatic experiences day in and day out, potentially, the toll can be extremely high. And we know that trauma is cumulative, and it's also what we'd say is it's developmentally bound, meaning the younger you are in your development, the more vulnerable you are to the effects of trauma. So children and adolescents are particularly vulnerable to the effects of trauma. And I'll also say that we tend to talk about big T trauma and little t trauma. So big T trauma are the events that most anyone would consider traumatic. So shock traumas, right? Where the person perceives a potential threat to their survival or the survival of their loved ones. So here we're talking about childhood sexual, physical, emotional abuse, rape or assault, the traumatic death or the murder of a loved one, combat-related trauma, and certainly in terms of first responders, events that they are responding to that don't go well, that overpower their resources, where they're left feeling ineffective, or that they failed, or that someone dies in a situation. Little t traumas are the experiences that people might not necessarily recognize as traumatic, or events that might not necessarily meet the official criteria for so-called trauma. So here, experiencing criticism, covert bullying in childhood, experiences of betrayal, experiences involving humiliation or failure or aloneness, subtle microaggressions, as well as blatant discrimination or hostility related to race or ethnicity or gender. So again, examples in adulthood might be a divorce or losing a job or a difficult move or the discovery of a partner's affair or situations where you think you've done a good job and then you get criticized for it, or you find out that other people are disappointed in you. Examples in childhood: feeling ignored, feeling different, feeling unable to measure up. And of course, these kinds of experiences in childhood set people up in their adulthood to be vulnerable to criticism, to be vulnerable to the effects of failure, to be vulnerable to the effects of being in situations where they feel powerless or overwhelmed. If you've experienced that in childhood and you haven't properly paid attention or processed those experiences in childhood, and you take those experiences in your nervous system into adult situations, where then you experience triggers similar to what you experienced in childhood, you're vulnerable to experiencing those situations in adulthood in a way that can feel traumatic.
Well, you mentioned the nervous system. So take a moment and talk about how trauma affects both the nervous system and brain function.
Yeah. Well, it's helpful to think about the brain as being made up of three smaller brains: the thinking brain, the emotional brain, and the instinctual brain. Now, the thinking brain is responsible for thinking, talking, remembering, reasoning, creating. The emotional brain is all about feeling, remembering, detecting threat, interacting with others. The instinctual brain is connected to sleeping, eating, breathing, heart rate, blood pressure. Rich, you can correct me if I'm getting any of this wrong. And in response to trauma, the emotional brain, in conjunction with the instinctual brain, mobilizes and winds up hijacking the thinking brain. The limbic system of the emotional brain goes into overdrive, and the sympathetic nervous system automatically kicks into high gear, and everything gets focused on survival. And the brain prepares you to fight or take flight, right? Your heart rate increases, your pupils dilate, airways open wider. We become hyper-focused, scanning for danger, looking for escape routes, and sometimes freezing when the threat feels particularly overwhelming and there's no possibility, or it feels like there's no possibility of escape. The thinking brain's kind of executive control network gets suppressed, and it kind of cuts out the thinking part of you, the decision-making part of you. And we just react, we respond. So ideally, after a trauma is over, the thinking brain is able to reestablish control. But in many cases, particularly when we're talking about situations where there's clear-cut post-traumatic stress disorder, the emotional brain remains stuck in overdrive, and it continues to inhibit the thinking brain's function. So people remain in high alert and particularly reactive to anything that reminds them of their traumas. The brain is not able to effectively evaluate whether someone or something is a real threat or not. And with prolonged or repeated exposure to trauma, this state of high activation, and again, we're back to thinking about first responders here, with prolonged or repeated exposure, this hyper arousal, this freeze, fight, and flight becomes chronic, right? Leading to potentially anxiety, difficulties with self-regulation day to day, irritability, aggression. And sometimes when the level or the duration of stress becomes too great, a person's nervous system shifts into a shutdown or a collapse mode, what we call hypoarousal. So many complex traumatic stress disorders reflect this chronic state of immobilization, right? It shows up as despair or hopelessness or numbing or dissociation. This is where we see the suicidality, where folks, they can't put one foot in front of the other anymore. They've started, their system, their nervous system has started to shut down, and they feel immobilized. And that is unbearable for so many people. And sometimes people turn to drugs or alcohol or food or sex or porn or other addictive behaviors to try to regulate their dysregulated nervous system. They might wind up avoiding situations that might intensify their anxiety or their sense of being out of control. And often it's the behaviors that bring people into therapy, perhaps I should say the behaviors that we most often see when people first come in to therapy are secondary to trauma, right? They're often symptoms that reflect a traumatized brain and nervous system. It may not even look like a trauma symptom right up front. It's that secondary reaction. It's the shutdown, or it's the drug abuse, or it's the anxiety issues that we see as people come through our front doors.
Thank you. It's very fascinating. The acronym that I used at the introduction, EMDR, what does EMDR stand for? And then what does it mean in like layperson's language?
Yeah. Mm-hmm. So I'll start with the acronym EMDR. It stands for eye movement, desensitization, and reprocessing, which is a mouthful. It's an earful. I think Francine Shapiro, the developer of this therapy, wished she never gave it this long, challenging name. Let me break it down. Desensitization refers to the reduction of distress, the reduction of fear and anxiety. Reprocessing refers to the reevaluation or the restructuring of thoughts and beliefs and feelings, and the transformation of one's sense of self relative to past traumatic experiences, right? We work to change the way folks feel about what they've been through and where they are in the present. It's about moving the past into the past. And then there's the eye movement piece of this. Now, Francine Shapiro, the developer of EMDR, accidentally discovered that purposely moving your eyes horizontally back and forth while focusing on a traumatic memory leads to a reduction in the vividness and the emotional intensity of that memory. And she developed an effective protocol for treating post-traumatic stress disorder and other traumatic problems, other trauma-related problems, using this bilateral back and forth eye movements. And she published her first research study on this approach in 1989. And in her original research, she worked with rape survivors and combat veterans. So hence the name eye movement, desensitization, reprocessing. I'll say more about that in just a moment. But EMDR is a memory-focused psychotherapy that basically helps people deal with the impact and the legacy of trauma and adverse experiences in their lives. And it's based on the idea that psychological problems are related to a failure to adequately process traumatic experiences and memories. So unprocessed traumatic memories, frozen or locked in our nervous system, kind of hanging out in our nervous system, continue to affect us. They continue to affect how we perceive things, decisions we make, reactions we have, the beliefs we hold about ourselves and others. And those frozen memories can get triggered. Present day triggers activate these unprocessed traumatic memories, leading to symptoms that cause ongoing distress. So in EMDR therapy, we help clients we help them identify and access and activate these unprocessed traumatic memories with a set of focused questions. And by focused questions, I mean, we might ask, what picture represents the worst part of that experience? What's the negative belief you hold about yourself still to this day that related to this trauma? what would you rather believe about yourself? If you could dump off this old trauma or transform this old trauma, what would you rather feel? What would you rather believe about yourself? What are the feelings that come up when you think about this trauma? Where do you feel the distress related to this trauma in your body? So with these questions, we activate the trauma, and then we introduce the bilateral stimulation, the eye movements. We ask people to follow fingers or to follow a light that goes back and forth. And we basically jumpstart the brain's information processing system using this bilateral stimulation. And with EMDR reprocessing, a client's distress eventually decreases and relevant other information gets integrated in, gets pulled into the processing to help people make sense, make meaning out of what happened, see things from a different perspective. So we might see people move to a place by the end of treatment where they're able to say, it's over. It's really over. I'm safe now. Or I was only a kid doing the best I could. If they're working on something from childhood, it wasn't actually my fault. People land in a place where they can say, I'm in control now. I have choices. The past is in the past. So there are shifts over the course of reprocessing in thoughts and feelings and behaviors and physical sensations in the body. Healing basically involves spontaneous movement toward more positive thinking, more manageable feelings, and a significant reduction in the level of distress or disturbance that people experience in their body. And basically, the theory behind EMDR argues that the mind can heal from psychological trauma in the same way that the body heals from physical trauma, right? So if you have an injury to your arm, you get a wound, your body is immediately going to mobilize to start to heal that wound. And if you don't interfere with it, you don't get the wound dirty, or you don't keep picking at that wound, it's going to heal. Right? You don't have to command your body to do anything. We'd say the same thing is true for psychological trauma. The brain knows what to do if the brain is in an optimal state, if that information processing system is mobilized and doing what it needs to do. So that's what we're trying to do in EMDR therapy, is we're trying to reactivate that traumatic material that's kind of been frozen or locked in the nervous system. And then with the bilateral stimulation, with the back and forth eye movement or whatever form of bilateral stimulation we're using, we jumpstart that information processing system and we move that information to a more resolved state so the person can rest, can experience relief.
Okay. Now, I'm sure that some of my audience, skeptical, disbelieving firefighters who might have the opinion, well, this sounds like a voodoo science. I know some of many of them are going to jump right into this, and I hope they buy your book as well, because you sent me a copy of the book and it was absolutely fascinating. But what I want to do now is I just want to take a moment and shift over to Dr. Kamin, because he was a recipient of EMDR therapy. And were you his therapist, or was no? Okay. No. And give him a chance to tell as much as he's willing to share the backstory of what led him toward getting EMDR therapy, and then what did it do for you, Dr. Kamin?
Sure.
You're the validation to this concept that Dr. Korn is laying out. So tell us how it worked for you.
So, yeah, I'm happy to. If for no other reason, I think that's the longest I've been quiet for a really long time. But actually, hearing Debbie talk about this is absolutely reassuring to me. Reassuring that I did the right thing when I made a decision to, even though I didn't 100% understand how EMDR worked.
Mhm.
And even though I wasn't 100% convinced that it may or may not work for me, I was in a spot where I wanted to do everything I possibly could to preserve my functioning and my sanity. And I had just come through an event. I'm an emergency physician at UConn Health in Connecticut. Part of my jobs, I have the honor of working outside the hospital. I provide medical support to law enforcement. And I work with 3 separate SWAT teams in the state. And 2 of the teams that I worked with were actually co-functioning at the Sandy Hook shooting or in the wake of the Sandy Hook shooting. And I got to Sandy Hook about an hour after the shooting stopped. All of the folks in that school had been evaluated and examined already by 3 very competent, qualified paramedics who made the 100% absolute correct and unfortunate determination that there was no one in that school that was viable, that everybody was beyond help. I got there about an hour after they had already made that determination, and very quickly realized in the process of going through and reevaluating everyone in that school that the clinical situation that I was presented with was absolutely something that I was prepared for. I had been working with law enforcement for 10 years. I felt confident. I was well trained. I was well equipped. I had a good relationship with both teams that were there and I was working with. Clinically, I felt as if I had been appropriately prepared to deal with folks who were acutely injured. I had worked in a level 1 trauma center for quite some time in Hartford, the whole shebang. What I wasn't prepared for was the emotional impact that I was going to be presented with. So and by the way, talking about Sandy Hook, I have spoken frequently in a lot of different places about my experience there, and I universally will not speak about clinical details. There's no utility. One-on-one, I'm happy to talk to people about what I saw and what was ultimately proven by autopsy. But it's not necessary for this conversation. What's important for people to understand is that I showed up with 2 teams that I was absolutely confident in working with. I felt secure, prepared. I walked in that school and there was no way that I could have been prepared for what I was going to encounter. And maybe even worse was that I wasn't informed about what I might encounter in the wake of it.
Right.
And so we went through the day and we did our job, and I left with this sinking feeling that I was broken. And I left with this just heartbreak that I was going to leave my wife and my 2 Sandy Hook age children at the time. I have 2 children who are now 19 and 16. They were Sandy Hook age at the time. Mm-hmm. I was going to leave my role as their father and as a husband and as a physician. I have now left it because I'm broken. And I was very, very lucky. Very lucky because in the wake of that, in the evening, I got wonderful, wonderful advice from my chair, who's a gentleman by the name of Rob Fuller, another emergency physician who does disaster response. And Rob has absolutely been there in a number of very, very catastrophic environments, 9/11, Banda Aceh, on the ground at Haiti hours after the earthquake. I mean, really, really absolute legitimate guy. And he called me up in his very Rob Fuller way. I'd known Rob for some time. I've been working with him for him since 2004. And Rob said, how you doing? I said, yeah, I'm doing okay. And in reality, I wasn't doing okay because I was already having intrusive thoughts. I was already seeing my kids' faces on the bodies of the people I had taken care of today. There was this horrible dread and worry that I was confronted with. I was actually looking down at my shoes, regardless of what shoe I was wearing, and I was seeing the boots that I had worn in that school covered with blood. So it was very, very scary for me. And Rob said, hey, by the way, just so you know, you're going to have intrusive thoughts. It's going to be hard to concentrate. You're going to be more irritable than normal, which, by the way, if you don't know me, is a trick. And it's going to be hard to sleep. Don't drink any alcohol or use any drugs to deal with this. If you're having trouble sleeping, let me know. I want you to exercise every day. I want you to eat as best you can. I'm going to pick you up tomorrow morning at 7. We're going to go work out. And I was like, okay. Tomorrow morning, 7, we did our thing. Later that morning, I went to a debrief with the FBI, one of the teams that I was at Sandy Hook with. And in the wake of that, a subject matter expert from the FBI said, hey, everybody, by the way, you know what's normal in the wake of something like this? You're going to have intrusive thoughts. It's going to be hard to concentrate. And they went down the exact same set of symptoms. And I thought to myself, like I frequently do, when two experts say the same thing and don't contradict each other separately, not in cahoots, but separately, it's really important to think about. That's probably a legitimate thing to think about. So I was relieved because what I was told was the vast majority of folks go through this and process this on their own. And a lot of times it's, people talk about 3 sleep cycles and needing, a good few days to kind of let the brain do its adjustment, kickstart itself, kind of go through the process. And that for the most part, most of us were going to be okay. And here's what you should look for. Look for persistent symptoms, look for worsening symptoms, look for a number of issues that could be indicative of someone that is not getting better on their own. And when that happens, call us up. Well, it was interesting. I was going through the post-Sandy Hook moment, having all these things. Going into my kids' elementary school was just horrifying for me. I mean, scary for a guy who is calm in the face of chaos. And I couldn't walk into my kids' elementary school without getting tachycardic and scared. And again, I was very lucky because someone had made me aware that that was okay. That was not abnormal in that moment. And I ran into a woman locally where I live who I had done some marriage counseling with. My wife and I had, kind of found ourselves at a place in our marriage where we went and got some counseling, and it was super successful, very helpful. And it was December, and this lady said to me, hey, Rich, how you doing? And because you shouldn't ask me that question without expecting the answer, I told her. And it was very interesting because she was very respectful and of course didn't pry, but she said, wow, I'm so sorry to hear you went through this. My best friend lost their grandchild at Sandy Hook. There was a connection there that rang true. And then this woman said, and by the way, I saw you and your wife for marriage counseling, but what I do full time is trauma counseling. And if you'd like, I'd be happy to meet with you and just talk a little bit and see if there isn't something that I could do for you in the wake of this experience. So I went in, all the symptoms still prevalent. It had now been a good couple of weeks not sleeping. I mean, I was getting thin. The veneer was super thin, right? And I was very lucky. Rob Fuller, my boss, had taken me off the clinical schedule for a few days, not mandated, but said, you know what, Rich, you'll come back when you're ready, which was tremendous because I was not ready for a few days. And I really, really needed to get my feet underneath me. So I went and I saw this trauma practitioner and they said, listen, I think I could help you. It's this thing called EMDR. And they knew me well enough to say, oh, let me show you this list of, research. And I said, hold off, time out. This is not my area of specialty. I have 3 questions for you. Number 1, my insurance will cover this. And she said, yes. And I said, okay, good. Number 2, you think it's likely to help? And she said, absolutely, I think it's likely to help. It's used by all these different organizations and the military uses it and all these response organizations. And I said, how likely is it to hurt me? And she goes, what do you mean? I said, well, what are the side effects? What are the complications that might? And she goes, they're not 0 and it's almost 0. And I will tell you that in my own practice, when I'm confronted with an intervention that is going to be covered, not expensive, is likely to help and not likely to hurt, it's something worth trying. And that's really what I made my decision about, because back to what I said originally, I was afraid I was broken. I didn't want to stop being a dad. I didn't want to stop being a husband. I didn't want to stop being an emergency physician. I didn't want to stop working outside the hospital with law enforcement. This was what kind of provided, all those things provided me. And so I took an opportunity to do some EMDR, and I found it tremendously helpful. So, and for what it's worth, Debbie and I didn't work together. I got contacted, in the wake of having already spoken about my experience with EMDR, to a large extent because I got unbelievably motivated at Sandy Hook to make sure that the same thing was less likely to happen to others who were willing to put themselves into an environment where they're exposed to traumatic events.
Right.
And to me, it was very unfortunate. And I still think unfortunate and important that we try to improve, Rich, I'm sorry, the situational awareness around this whole issue. There you go. Because it's something we could do something about.
Yes.
So understanding it, it's not overly complicated. It's not just for the PhD psychologists like Dr. Korn. It's for silly emergency physicians like me too, and for every skeptical firefighter, which I have many close friends like that. It's just something that we should understand what's going to happen to us simply because we've chosen to put ourselves in this environment. We should know what it's like.
Mm-hmm.
We should understand what we can do to make ourselves more resilient, less subjective to it. Know what we should do when we find ourselves in the midst of a situation where we think we're maybe being traumatized or we're being exposed to something that could be traumatic. And then last but not least, absolutely have in our pocket what we're going to do as far as resource and expertise in the wake of realizing we've been impacted.
Well said.
Yeah, very well said.
Well said.
What I would like to do, if the two of you would be agreeable, is I'd like to, in reference to the book, it talks about the phases of treatment for EMDR.
Mm-hmm.
And I think if my memory serves me right, there's eight steps or 8 phases to it. If the two of you could play off of this, and that Dr. Korn would talk about the first phase, and then Dr. Kamin could say, and here's what first phase meant for me, so that you could say, give the clinical explanation of the phase, and then Dr. Kamin could give the patient's view of what that phase was and how you maneuvered through that, so that maybe we could talk that skeptical person through that 8-phase process. I think of it kind of like you're getting ready to go into surgery, and the surgeon says, okay, you're going to be okay, and there's just this tiny possibility of complication, but you don't really know, like, once you're anesthetized, you really don't know what they're doing, step by step. Here we can go step by step and say, here's the steps, here's the phases. One of the things that I'm sure there's some curiosity is, am I going to be hypnotized? Am I even going to be knowing what they're doing to me, as they're manipulating my brain? And so could we work through those 8 phases?
Yeah.
The two of you, I'll just kind of sit on the sideline and be a observer to this conversation.
Yeah, I wanted to just say one thing about the 8 phases before Rich and I go into this. And that is that the phases aren't linear, right? It's not we go from here to here to here. There's some of that, but it's much more like a boogie woogie 2-step. We go forward, we go backward, we go to the side. I'm tracking the client and going to whatever step in our protocol is needed. So it's not as clean as a linear process, but this should be fun, Rich. Let's see if we can walk through this a little bit. And I'll also just say that, when I'm working with somebody that's coming right off a critical incident, somebody, who's been exposed to a trauma in the last days or weeks or even months, the protocol, the way of working is slightly different, but let's play around with this anyway.
Well,
So,
and Debbie, before you get going, I just want to also say that it's super critically important. People are going to listen to this and maybe think about how EMDR could be useful for themselves. It is super critically important that you find someone who is qualified.
Yeah.
And that they're, like everything else in the world, are people that are really good at what they do and people that are not so good at what they do. And it's just really important that this is one of those moments. Trauma treatment is one of those moments where you really want to make sure that someone's the right person and they're qualified in the right way, because
Okay.
it's not a simple linear protocol.
Okay. Now
No.
we have to put a pause on this 8-phase discussion because you said it, Rich. Now we got to unpackage it. How do you find somebody that's qualified, and how do you know if they're qualified? You know, I think that's the challenge that everyone has when they go to any specialist for any treatment. You know, I just recently, for example, had a root canal, and I went in and I met the doctor, and I thought, well, they seem nice. I hope they know what they're doing. You know, I really didn't do. It was a referral from my dentist to the specialist, so I kind of had some faith there because I didn't think my dentist would guide me in the wrong direction. But let's say a firefighter goes to their general practitioner and they say, you need to have some specialists. Here's how I would see it. You need to have some specialists. Okay, I'm going to call my insurance to see what's covered, to see who's out there that's on the list that the insurance will pay for. And then I'll call up one of them and make an appointment. And how do we vet it? How do we know that we're getting somebody who can really help us?
Yeah.
And I want to pause the back and forth banter about the 8 phases, because Rich brought up such an important point there of how do we find that right person.
Yeah. I totally second that recommendation, that thought. It's so critical that you find the right person for you, which is not necessarily, the right person for your neighbor or your friend, but the right person for you. We have an entire chapter in our book about, once you're ready to seek treatment, how do you go about finding a therapist? What are the questions you can ask someone? Where do you go to get names? What are the questions you ask? So if folks are interested in finding a qualified EMDR therapist in their area, they can certainly go to our website, which is everymemorydeservesrespect.com. It's just the name of our book, everymemorydeservesrespect.com. And there's links on our site that will take you to the EMDR International Association Find a Therapist directory. And there you can plug in where you're located and get a list of qualified therapists. And there's levels of credentialing. So if you want someone who is the most credentialed, it would be somebody who's a certified EMDR therapist or a consultant in EMDR therapy. But even if they're not available or you can't find someone in your area, you can contact people in your area or nearby and ask them, who do they practice with? Who do they consult with? And you can do a little bit of networking that way. Not every single EMDR therapist belongs to the EMDR International Association. It's a membership organization. But, so it's reasonable to see someone who's not necessarily a member of the EMDR International Association, but you want to work through someone who's a certified therapist or a consultant to try to find someone. And, we really are a community that wants to end suffering in the world, and we really want to be helpful. So if you reach out to somebody that you connect to through the EMDR International Association, we will do our best to try to get you connected to someone in the area. And like I said, in our book, there's a series of questions. You want to know, what does the person specialize in? What's their level of experience? How long have they been practicing EMDR? And you want it to be someone you feel comfortable and safe with. Your body will tell you in the first couple minutes of talking with someone, whether this feels like someone that is hearing you and getting you. And, your nervous system starts to settle as you engage with this person. I was listening to Rich talk about running into his marriage counselor and, how immediately he felt comfortable to share with her what was going on. And my guess is, if that had been someone you didn't feel safe or comfortable with, you might not have been likely to open up about what you were going through. So really trusting your felt sense of, does this person get it? Does this person feel safe? That's critically important as well.
Yeah. And Rich, if I can, and then everything Debbie said, and from a consumer's point, from someone who spends a fair amount of time helping people get connected to qualified therapists. And by the way, I don't have, Debbie keeps saying our book. I wasn't involved with the writing of the book. It's a great book. And I have no financial interest in any one practice, right? And what I think is also very important is that, there's a reason why folks that are athletes, whether it's super organized or not, high school, college, professional, semi-pro, all those folks have an orthopedist, have a sports physician already in the book. Well, listen, what I do for a living, and Rich, what I know you did for a living, at least for a little while, you may still do, and what a whole bunch of people who are watching this, is the time to find these folks is not in the wake of the terribleness, on the morning that you wake up and go, oh, I think I want to go see an EMDR specialist. The time to find these folks and have someone's name and number of someone who's respected, and even if they're full and they can't take care of you, will tell you somebody else that's good to go see, is long before the event happens. And again, part of that, tremendous cultural shift that I think the universe of responders and folks who do this kind of work day in and day out really have to get ahead of.
Mm-hmm. Yeah, Rich, your point is so well taken. If I had my wish, my heartfelt wish, every response team, whether it's, doctors or firefighters or police, they'd have their own, they'd have their own team of therapists ready and waiting, with relationships established, so that if any of these responders find themselves not moving through that initial acute trauma phase, right? It's not unusual to have the kind of symptoms that Rich was describing after exposure to traumatic situation. But when they find themselves not moving through it, their brain isn't naturally processing it, and their body is starting to discharge some of the material that it's holding on its own. It would just be remarkable if they knew exactly who to turn to, pick up the phone, and, within hours be able to talk with someone and schedule an appointment to do the work, because we know how to address this. We know how to help people dump this stuff off and return to functioning, return to a sense of peacefulness in their day-to-day life. People may be forever changed by what they're exposed to. Like, I suspect, Rich, that you will always carry Sandy Hook with you in some way. It affected you, but it's not haunting you anymore. It's not part of your day-to-day existence anymore.
Yeah, I mean, the way I think about me after Sandy Hook is that I'm absolutely a different person,
right?
Before and after. And I was greatly relieved when I was told I wasn't going to have to walk with a limp for the rest of my life, because I thought, even if I did get through this, I was going to be walking with a limp. And I had a number of, people who I trusted, and they said, listen, I know a lot about this. You don't have to walk with a limp. You just got to get ready to do some work. And the only other thing I want to say about having a resource like Debbie talked about, how every team, this is becoming more and more acceptable. The folks who do this work are becoming more available in that, there's more of them who are expert and good at doing what they're doing. Is that it's not just in the wake of a bad event.
Right.
It's when a group of folks commit to putting themselves into a potentially traumatic environment day in and day out, right? And whether you're a physician, a nurse, a firefighter, EMS provider, law enforcement officer, et cetera, that, as I'm going through my divorce, when I'm dealing with my parents' death, when something funky happens with a kid, and I still have to do my job, right? So it's really about looking at like human being 101 a little bit differently. and listen, I'm sold, right? I'm biased because I've had a lot of success. I've already told you I've been through marriage counseling. It worked really well. I've already told you I've been to EMDR. I'm a huge proponent. Like this, in my opinion, is how we take care of ourselves sometimes. You know, I go to the gym, I eat well, I quit smoking, et cetera, right? I also do stuff to kind of keep this part a little better organized when I need to get a little better organized.
Mm. And Rich and I were talking right before the program today, and I was saying that it's so critical when we are involved in work. We, again, all of these folks that do this work day to day, it's so critical that we keep up with the trauma within ourselves, right? That we process as we go, that we don't let it accumulate to the point where we have to do something to keep it at bay, push it to the side because it's in there and it's activated and it's unbearable. If we keep up with it, if we're processing as we go, the way we go to the gym, the way we put good nutrition into our body, if it really is part of our self-care, then our first responders, then our caregivers are not going to be getting burnt out. They're not going to be shutting down in their families and struggling to take care of their kids or tend to their marriages, right? They're going to be able to stay fully present in their world rather than overwhelmed and having to turn away from things.
Fantastic. Fantastic. I'm glad we took that little side trip
Mm-hmm.
and had that conversation. So if we could come back to the phases and each of you talk about what the phase is and how you went through the phase. And again, with consideration for the fact that, as you said, Dr. Korn, it's not linear. So
Yeah.
and maybe it wasn't, maybe the phases weren't conducted in 1 through 8 order for you.
Yeah. And the average client wouldn't know, oh, we're necessarily in this phase. I don't expect my clients to kind of know the phases. That's for the clinician to know.
Yeah.
But so if someone were coming into treatment soon after traumatic exposure, right? Days, weeks, months, as in Rich's case, the first thing that would happen is that the therapist would introduce some coping skills, do a little bit of preparation, do some education about trauma, do maybe teach some skills for grounding in the present moment so they don't get overwhelmed by what's going to be brought up in treatment. Really get to know one another a little bit so there's safety in the moment with the therapist. We teach clients about what we call dual attention, which is this idea that you are always grounded in the present moment as we dip back into that trauma, right? You always have one foot in the present as we activate or bring the trauma. So that's part of that education that we do right up front. So Rich, any comment on where you started?
Yeah, well, I mean, a number of those boxes had already been checked because I was lucky enough to be working with someone that I knew and that had already proven to me that they were capable, reasonable, objective enough so that I could be in a room and hash stuff out with my wife and still feel like I got listened to. Important. And then I think the other thing that was reassuring for me, Rich, to your point, like, I didn't really care if I was going to get hypnotized. What I was really worried about was that my memory was going to be erased. And that because I had, again, pretty quickly after Sandy Hook, wasn't married to the idea of remembering every detail because it's an event I want to keep fresh in my memory. I was committed to not losing clarity on the event because I thought it was such an important historical event, an academic event, and I had been through something that now I was very, very committed to teaching other folks about as far as response and preparation and what to do in the wake. So I was really worried that in the process of relieving of myself of the impact from this event, that I was going to be less clear about it. And actually, what I was told and what turned out to be was that I became more clear.
Mhm.
I was told it was going to happen. That in the process of going through getting some EMDR and some therapy around this work, I was going to be able to think more clearly about it. And that is 100% true. If for no other reason, I'm no longer activated in the same way that I was, right? So there's a period of time I could think about Sandy Hook, and I was thinking a lot, many different kind of insults or inputs, and it would be very hard for me to remain thinking about that because I would get anxious or, like I said before, tachycardic or get very worried, somewhat overwhelmed. That's gone away, but the event's still there. My memory is still there.
Mhm. Yeah, I always say to clients, EMDR is not going to take anything away from you that you need to be able to go forward in life, to make meaning out of life. Lots of times when people come into treatment and they've lost someone important to them and they're grieving, that it was a traumatic loss, they're afraid, am I not going to be able to remember this person that I've lost? Am I not going to be able to, access images or their voice or whatever? And I always say, no. EMDR is not an erasure technique. It's not about getting rid of the memories. It's about reducing the suffering, reducing the amount that the most traumatic parts are haunting you, so that you can think about this person, so that you can remember what's important. And it's not gonna, people also worry, particularly first responders worry, that they're somehow not going to be vigilant enough if they let go of what they experienced, the lessons learned about certain circumstances. Childhood trauma survivors, if I stop being vigilant, am I not going to be able to protect myself or take care of myself? And I always say, no. If we can kind of move the traumatic material into its proper place, then your nervous system will be in an optimal arousal zone where you can think clearly and you can respond clearly and you can discern what's needed in the given moment, right? Situational awareness. You will be able to see with clarity what your choices are in that moment, and you'll know that you have choices rather than reacting or shutting down, and without things happening outside of your awareness. You'll be more effective. So anyway, back to the 8 phases. Typically, I jumped right over the first phase. Typically, when people aren't coming in for immediate trauma, recent trauma, the therapist takes time to take a more extensive history about traumatic experiences of one's life. Maybe it was an entire childhood of traumatic experiences. So typically, phase 1, we take a solid history. We do some treatment planning with the client. We explain to them kind of how treatment is going to unfold. It's a collaborative process. We want people to feel like they know exactly where we're heading in this work. No surprises, right? We want to be on the same page before we launch. When somebody comes in with more recent trauma, we're not going to take an extensive history. We're really going to focus in on that recent trauma, and we're going to begin preparing them to do work on that recent trauma quite immediately. So once the basics are established, right? The education is offered, the questions are answered, the relationship is in place. Rich was lucky enough to have that relationship in place heading into this work. Then the therapist would ask the client to tell the story of what happened from before the event, from just before the event until the present time. And as the client is telling the story, they are engaging in bilateral stimulation through the telling. So typically what we do is the therapist might tap on the client's hands as the client rests their hands in their lap while the client is, the different therapists do different things. Some therapists might have the client, again, watch their fingers go back and forth, or if it's virtual, they might watch a ball on the screen go back and forth. If it's in person, the therapist might tap on the client's hands as the client watches the therapist's hands go back and forth, tapping back and forth. So the client is moving their eyes back and forth, watching the hands as the therapist taps. There's other ways to do that. but the client tells the whole story with bilateral stimulation. And then once that is done, the next step is the client is invited to return to reflect on the story, to see what part of the story pops, what part is most activated. It kind of jumps to the foreground. And whatever that is that jumps up, that feels most disturbing as they reflect back on the story that they've just told, that becomes the first target for EMDR, the first memory or the first segment of an experience that we're going to focus on. So Rich, you can talk about perhaps your first target.
Yeah, and well, actually, the first one for me was less important for the fact that as I told the story, I had a number of persistent components of my event, the images stuck with me. And I'll tell you, one of the things I felt really horrible about was telling this story to someone who had not been there, but who had been not only personally impacted, but was in no situation prepared to hear about this. And the story that I told this person was graphic because the nature of the things that were bothering me were graphic. And that was something that I struggled with, quite frankly, in that the person I did the work with did a wonderful job of reassuring me that this was their job and this was what they were prepared to do, and that they had their own process for dealing with however they may or may not be impacted by it.
That's
so
right.
I went through the telling, and I ended up with a list, an agenda, so to speak, of images that we got ready to go to work on.
Right. Right.
Rich, what was your bilateral stimulation during the process?
So the storytelling, I didn't. There wasn't specific bilateral stimulation during the storytelling, the agenda setting for me, and I used a number of different forms of BLS, of bilateral stimulation. And that is, I did most comfortable. I was with just following the therapist's finger. That worked very well. I also kind of do what's sometimes referred to as the butterfly tap, right?
Butterfly hug.
Butterfly hug. Tapping in my lap was good. That also worked. And then I'll tell you, the things that worked for some people didn't work for me was sometimes people use sound that moves back and forth.
Beep, 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 beep.
Yep.
Right.
And then there are these haptic devices that will,
Vibrate
in your hand rhythmically.
back and forth. Yeah.
Those didn't do much for me either. And quite frankly, it was part of that important process was not so much which one I decided was most effective, but having the opportunity to know there's a bunch of different ways we can do this. Well, let's see what feels best for you. Yeah.
Right. And so once we've identified a target, and it's worth saying that it's also possible to do EMDR without the therapist knowing much at all about the target. There's a protocol called blind to therapist, where basically the client just has to kind of give a title or a headline of what they're working on, but they don't have to share it. The most important part is that the client activates, brings that memory into the present, into their working memory, and focuses on it going into the work, but they don't have to share. So for people who have lots of shame about the experience, for people who are worried about traumatizing their therapist, even if the therapist reassures them, they don't have to share much. They don't have to talk about it much. It's one of the beauties about EMDR compared to talk therapy, where the cure is about talking through what happened. You don't actually have to do that in EMDR. What's most important is that the client focuses in their mind's eye and in their body on what is activated. But so once we have a target, then the therapist activates that target again with those series of questions. What picture represents the worst part? What's the negative belief about yourself that comes up with that? What would you rather believe about yourself now going forward? how strong is that positive belief, the belief that you want to lean into, that you'd like to get to? How strong, how true does that feel now? And most people say, oh, that doesn't feel very true at all. I'm safe, or it's over, right? What feelings, what sensations are coming up for you? How disturbing does it feel at the beginning of the work? We always get a baseline asking people to tune in and be mindful of their bodies, so we know whether the treatment is working, right? Is that distress going down over the course of the work? So we go through the series of questions. We ask the client to focus on the image, the feelings, the sensations, and then we begin the bilateral stimulation. We begin and we do sets. We do sets of bilateral stimulation, maybe 30 seconds to a minute, where the client is just following the back and forth stimulation. And then we check in. What do you get now? What do you notice? What's happening? Client reports, we do another set. Keep processing, client reports. So Rich can tell you a little bit about his experience, and this is called the desensitization phase.
Yeah, and it's just as Debbie said. I mean, it was very simple. No one ever asked me, and I reassure a lot of folks, no one ever asked me when I stopped breastfeeding and when I was finally able to get out of diapers. You know, there wasn't a lot of stereotypical back and forth in regards to experiences that people, I think, sometimes imagine would be involved with getting therapy. But what was important was this commitment to having a clear idea of what was troubling me and trying to be committed to having a sense of how it was troubling me. And sometimes it meant, like, you know, that spot in between your scapula that you just can't stretch, you know, that sometimes that's where it was. Sometimes it was my neck, and sometimes I actually felt a certain way. And it wasn't always the same. I have this uncanny ability to start yawning. I get very sleepy when I start to get overwhelmed. And that's, you know, all this stuff was exactly like we said, and go through the process. And then this awareness, which again, right, I hate to sound like a fanboy, but I was so relieved when I started feeling relief. And I was so relieved when, you know, I remember looking at the person I was working with, and I was like, yeah, I feel better. And they're like, yeah, of course you do. Yeah. And I was like, oh, it's that simple? They're like, yep, let's keep going. So that, again,
Yeah.
but there was a process for me where I was grateful that I was able to silence the critic in my head. You know, being someone who's very critical, being someone who kind of prides themselves on being a scientist, and to some extent, and to being as thoughtful and vigilant as possible. I really did a good amount of work of reassuring myself, like, you're in the right place, you're in a safe place, this person's going to help you.
Yeah. And during this phase, the desensitization phase, where we're basically saying, just notice, right? Just follow my fingers, just notice whatever comes up, no supposed tos, no shoulds. Your brain, it's just doing the work. We're just going to let your brain do this processing. Your brain knows what to do. And the therapist is just there to say, I'm right here with you. You're not alone. We're in the tunnel. We're going to get to the other side. Just stay with it. And it's an organic process. You know, folks feel feelings. They struggle with beliefs that are haunting them, right? It was my fault. I should have done this. I should have known better, right? People often see details about what happened that they hadn't remembered, like, oh, I did do this. It wasn't that I forgot to do this. Or there's a reason why I said what I said, or I reacted in that way, right? So the pieces of the puzzle start coming back together again, and they're able to integrate it and make sense out of it in a way they couldn't before, because the record was skipping, right? Everything was stuck. And often people are even able to imagine going back into a scene and doing something different. Like, I wish I could have. Okay, see yourself doing that. A lot of the time when I work with folks around childhood trauma, they're stuck around a place where they froze, or they didn't fight back, or they didn't speak up, or they didn't save someone. And, we'll just say, okay, go ahead and say what you couldn't say back then because you were little. Go ahead and do what you couldn't do back then. And we let the brain complete a circuit. We let the brain get some closure, and then they're able to let it go and move on. So, so there's really this sense of completion. There's this sense of integrating pieces of a puzzle and making meaning. But we know that we're getting to the end of the desensitization phase when we check in and say, okay, go back to the original incident that we're focusing on. How does it feel now on a scale of 0 to 10? When they started at a 10, high distress, when they're able to say it's a 0 or 1, right? The distress has come down. There's been a desensitization. And then we move on to the next phase around that target, which is the installation phase, where we say, okay, when you think about this incident or this part of the incident now, what are the positive words that you had said you wanted to be able to embrace, to integrate, but you couldn't at the very beginning? And they say, they want to be able to say, I did the best I could. Or they want to be able to say, it's over, I'm safe now. And we ask them to hold the original incident and the positive belief, and we keep processing. We move in with more sets of bilateral stimulation, and they continue to hold that positive belief. And lo and behold, that positive belief starts to settle in their nervous system. It starts to feel truer and truer for people as the brain does its work. So Rich, do you want to say something about that?
That was just my experience. And I would say that the only thing that I found a little interesting when I was doing it was the discussion around, okay, Rich, where are you? I'm like a 2, 2.5. Okay, let's do some more. Okay, Rich, where are you? I'm like, 2.5, 3. And there were a couple of issues in the wake of Sandy Hook where we kind of realized like it wasn't getting any better. And then it was, all right, well, I'm not getting to a 0 or 1, and how do I feel? Right. And the reality was that, what felt like a 2 or 3 maybe was going to be my 0 or 1. And that was okay. So it wasn't a hard stop. It wasn't a keep flogging until we get to 0 to 1. And there were also times when the person I was working with was a little insistent, like, yeah, okay, you say you're at a 0 to 1, and I want to keep doing a little more work.
Right.
And part of that was, again, me just being willing to trust the process. And so, yeah.
Right. So you're making a good point, which is that not everyone gets to a 0. Sometimes we get to a place where a 1 or a 2 or 3 feels appropriate to the situation. And there are some times where we say, well, what's keeping the 1 from becoming a 0? What's keeping the 2 from going to a 1? And there's some sort of blocking belief, like, if I actually totally let this go, I won't be able to be vigilant enough. I won't be able to protect myself. Or I'm afraid that if I really let this go and put it into the past, I'm going to forget this person, or I'm going to forget what I learned. So we just keep processing that. And for many people, we do eventually get down to a 0 or 1. And once we have, we've brought the distress down, once we've brought that new, more positive belief into the picture and integrated that, we always go back to the body. Is there anything left in the body? When you think about this incident, check your body. And if there's anything that's still left in the body, any tightness or heaviness or distress, we continue to have the client focus on that, and we keep processing. When we have finished work around a particular target, we go back to that, what we call it a Google search. We go back to the Google search, which is let your mind just go through the event again. Is there any other part that's still popping up, that's still a point of disturbance? And that's how we come up with the next target, right? Sometimes we have our targets lined up from the very first telling, and we know exactly where we're going. But other times we want to see after the work that we've done, and we go back to it now. Is there anything popping up now? So it's this ongoing circular process where we go back again and again to the history. We go back and again to the experience to see, is there anything else, right? Somebody may have started with a focus on fear that's in the body, and then they move on to feeling guilt, or they move on to feeling worry about the future, or some other experience from their life starts to, we find out there's something connected in another memory network that's intruding in, and we go to that. So it's this process of going back and reevaluating again and again. Is there more? Are there other things? Are there things even from childhood that got stirred up by this event that we need to go back and work through? So that's the process over the course of time. It's important to say that there is a phase called closure, which is what we do at the end of every session with clients. We've taken this deep dive into traumatic material, into big feelings, and we want to make sure that before somebody leaves the office, they go back out into the world, everything is settled in their nervous system as much as possible. They're able to put it away in some kind of imaginal container, or they're able to really kind of look around and reorient fully to the present moment so they can go back out and go into their job in the afternoon. So we always make sure we leave time at the end of the session to help folks put it away until the next session. Anything else you want to share, Rich, about? Oh, actually, there's one other thing I want to share, which is we always say that EMDR is a three-pronged process. So we help people with the events from the past. We help folks with the triggers, the situations, people, places, things, feelings that stir up past trauma in the present. Those become our targets sometimes. The trigger situations are what we target. And then we also move into the future with people, which is we help them in this new place. Once they've dumped off the trauma, they've transformed the trauma, and they're sitting in a different place internally, we help them imagine the next step in their lives, which may be going back to the ER. It may be going out to their next fire. It may be going back to work. It may be dealing with your children. It may be being able to watch the news again at 6 o'clock. Whatever it is, whatever those avoided situations or those dreaded situations, those trigger situations are, we help the person to be able to play a movie with the new belief, right? The new belief is, I'm okay, or I have resources available to me, or I'm safe now, or it's over, or I'm competent. Be able to carry that into imagining themselves coping effectively in that future situation, playing a movie. And if at any point they get any distress, any little spike of distress, we move in with the bilateral stimulation again to help lower the distress so they can play a movie of themselves in the future doing what they need to do. Any comment, Rich?
Yeah, no, I guess what I would say is it's interesting to me hearing you describe this, and because some of it was overt and some of it was very subtle, but nonetheless accomplished. When people talk about watching the news, I completely turned off the television except for things that I was streaming because I couldn't stand hearing that introductory music that comes when they're about to tell you that it's going to snow in Connecticut, and they're treating it like it's some pending catastrophe. And the same music that they play when it's going to snow in Connecticut in February is the same music they play when, people are killed in a mass murder. And I got that so frustrated me and so angered me and so activated me that I stopped. And one of the things I realized, in addition to being able to go back into my kids' school, was that I was able to watch the news again. I was like, oh, yeah, it's just as annoying. It's just not, impacting me so much. And the only other thing that I would ask is, for me, I found this to be a fairly precipitous change, right? And I was given some sense of how long it might take. But one of the questions that I was frequently asked is this going to be is this a 30-minute deal or is this a 30-year deal? And I would say, my experience around Sandy Hook is I did less than a dozen sessions, and by within 6 to 8, I was feeling good, not good, but I was feeling much better and way more grounded. And then there was just a couple of follow-ons, but like within a dozen, I was there. It was done, and the person I was doing the work with was like, "Listen, we can keep going if we can figure out something to keep going on." But and I was really relieved, and that to me was important because I
Yes.
know people worry about the investment they have to make.
Yeah. And I always like to mention a recent meta-analysis, a recent research study that looked at 11 trauma-focused therapies, all trauma therapies that have very solid evidence base, a lot of research to support their effectiveness. And this study looked at 11 trauma-informed therapies and concluded that EMDR was the most cost-effective treatment out of these 11 therapies, right? So you're taking the best of the best, and EMDR was the most cost efficient. So it's not just an effective psychotherapy, but it is cost effective, meaning it's an efficient treatment.
Right. Which is actually, from a almost lay person, right? I'm not a psychologist. From a consumer standpoint, one of the things I wondered about was, okay, well, I could do EMDR. What else could I do? And I felt, because remember, the person I had met with hadn't done EMDR, and I was like, well, if EMDR is so great, why wouldn't we do it when I was here doing marriage therapy? And they said, well, there's different tools in the box for different issues. And one of the interesting controversies around EMDR is that it's not the only proven approach to helping people with trauma. It's just a unique kind of approach that has a lot of proof and support for the intervention, and that there's lots of games in town. This just happens to be one that I got a lot of relief with and found it to be super efficient, all right, and very convenient because of the protocolized nature, because of the framework and structure of the work, and was just tremendously helpful.
Well, thank you. We're coming up on the 90-minute mark, and I know the doctor came and had a hard stop that he needed to be done by. So what I want to do is I could just sit and listen to both of you like the whole day long, but we're at a time limit here. So what I'd like to do is give Dr. Kamin the first swing at this final question, and then Dr. Korn the closing, and that is, Dr. Kamin, what would you want to share with the audience of first responders that you haven't shared yet because I didn't ask the right question to give you the chance to say that?
That's a good question. Because actually, because you did ask the right question, actually, and I worked it in, because what I feel really strongly about is that the nature of my work is being prepared to address emergencies or issues that I can do something about. And this is something that is a normal response to a very, very common kind of occurrence in a lot of our day-to-day lives. And that if we are not preparing for how to make ourselves, more resilient, before bang, right? Left to bang, we're getting ready to be ready. We're making ourselves stronger, more capable, more confident, doing what we can do in the intra event, which we know there's also things that you can do to lessen the impact that these things have on people when they're responding or involved. And then right a bang, what we need to do to take care of ourselves so that we're ready to go again when the bell rings. Because it's not if the bells are going to ring, the bell's going to ring. And I am committed to being ready to go. And so that's my thing. There's lots of good stuff. And that we're missing a real opportunity to be prepared to do it if we just don't take a little bit of effort to get ready to do it.
Good, thank you. Dr. Korn, what would you want to say to the audience that you haven't said yet because I didn't ask the right question?
Well, I think Rich hit it right on the nose. My message is actually very similar, which is don't wait. Don't wait. Trauma is cumulative. And if you don't address it right up front, if you're struggling in whatever way, even if you think like no one else is struggling in this way, you know, it must be me, it must be my character. I don't know if it's about the trauma. Whatever you're saying to yourself, get to the other side of that, reach out for help. You don't have to do this by yourself. You know, trauma does affect people. It's a brain injury. It affects the brain. It's not about character. It's not about who you are. And with the right help, you can get back on your feet again quite readily and keep doing, hopefully, what you love to do and what the world needs you to do. And you don't have to figure it out before you knock on a therapist's door, right? Just bring your whole hot mess, bring it, put it down in front of the therapist, and we know how to meet you there, right? That's our training. We know how to meet you there and move you through it and get you to the other side.
Fantastic. Thank you both for the gift of your time to share two unique perspectives, one from the practitioner and then one from the patient's point of view. I think this episode is going to be a fantastic resource for first responders, and I so look forward to sharing it with them. If they wanted to follow up, we'll leave you out of this one, Dr. Kamin, because I don't want to first responders following up with you and asking you more about the questions of being a patient. We'll let that stand with some confidentiality between you and your practitioner. But Dr. Korn, if they wanted to learn more, would it be through the book? And I want to plug the book and say,
Thank you.
Thank you for sending it to me. And I read it cover to cover, and then parts of it I read a second time.
That's great.
I really enjoyed, and for those who are interested, Michael Baldwin, the co-author with Dr. Korn on this book, shares his perspective from the patient's point of view, much like Dr. Kamin did here today. But if they wanted to learn more, is there resources in the book that can guide them to the answers to more questions? Or I know you said that there is a chapter in there about, what to do when somebody decides that they want to get therapy. Is that the best place to go?
Yeah. I mean, the book is really comprehensive. It's really accessible. It's written for the average layperson. It's written in accessible language. And my main objective in writing the book was to answer the questions that I hear all the time and to make sure that somebody could go to a section of the book and get answers to those questions. I'd also direct people to our website, again, which is the name of the book, everymemorydeservesrespect.com. There's lots of podcasts and interviews there if people prefer to listen rather than read. There are lots of resources on the website about trauma in general, trauma recovery, and EMDR more specifically. And people can write to us through our website as well.
Fantastic. Okay, thank you both. We're going to close here.
Thank you, Rich.
All right, thanks very much.
Rich.
Thanks much.
All right, bye-bye.
Take care.
Bye.
Bye-bye.
Thanks.
Thank you, Dr. Deborah Korn and Dr. Richard Kamin, for sharing your expertise on eye movement, desensitization, and reprocessing from the provider and the patient view. I want to take a moment to thank those agencies that have recently hosted some live situational awareness events. The Ohio Fire Academy, the North Carolina Fire Chiefs Association, Syncrude Oil Refinery, the Fire Department Safety Officers Association, Nuclear Fuel Services, the Thomas Jefferson National Accelerator Facility, the Association of Traffic Safety Services, the National Safety Council, Alcona County Firefighters Association, and the Power Test Conference. If you're interested in where we're going to be upcoming, visit the samatters.com website, click on the live training tab, and then click on the live training dates tab. And that'll give you a list of everywhere that we're going to have programs upcoming or have in the past. In January 2022, I trained and certified a cadre of master instructors to help with the growing demand for the situational awareness consulting and training programs. One of our master instructors, police officer Drew Moldenhauer, and I jointly authored a book to help police officers improve situational awareness and high-risk decision-making. How smart police officers use situational awareness to improve safety is available on our website store at samatters.com and also available on Amazon. If someone important in your life is a law enforcement officer or a security officer, you're going to want to get this book for them. And for a limited time, you can get a discount using discount code SAM20 to get 20% off the book. If you're interested in hosting a live event or a virtual training event, just click on the Contact Us tab at the top of the samatters.com homepage, and I'll give you a call. Finally, remember to check our show notes for how to subscribe to our newsletter and how to follow us on social media. There we share ideas about how to improve situational awareness, how to make better decisions under stress, and how to improve the skills of critical thinking and resilient problem solving. Well, that's it. Episode 393 of the Situational Awareness Matters show is complete. Thank you again to my guests, Dr. Deborah Korn and Dr. Richard Kamin. And thank you, our viewers and listeners, for sharing some of your valuable time with me today. I really appreciate your support of the SA Matters mission. Be safe out there, and may the peace of the Lord and strong situational awareness be with you always.
You've been listening to the Situational Awareness Matters show with Dr. Richard Gasaway. If you're interested in learning more about situational awareness, human factors, and decision-making under stress, visit his website, samatters.com. If you're interested in booking Dr. Gasaway for a program, or if you would like to be a guest on his show, click the Contact Us tab at the top of the homepage.